Welcome back, everyone. Let's continue to our final lecture on cardiology and cardiac surgery with cardiopulmonary bypass. Cardiopulmonary bypass is routinely used during cardiac surgery and thoracic aortic surgery to provide a still, bloodless operative field by temporarily bypassing both the heart and lungs. The CPB machine maintains systemic circulation and oxygen delivery while surgeons safely operate on the heart. The four principal functions of cardiopulmonary bypass are oxygenation of blood, ventilation through carbon dioxide removal, maintenance of systemic circulation, and regulation of body temperature. Together, these functions allow the heart to be safely stopped while preserving perfusion to vital organs. Components of the cardiopulmonary bypass circuit. The CPB circuit consists of several major components working together. First is the arterial cannula, which returns oxygenated blood back into the patient. Cannulation is commonly performed through the ascending aorta, although the femoral or axillary arteries may also be used. Second is the oxygenator, which replaces lung function. It contains a membrane oxygenator, a defoamer, and a heat exchanger that controls blood temperature. Third is the pump, which generates blood flow. Two types are commonly used: roller pumps and centrifugal pumps. Fourth is the venous cannula, inserted into the right atrium, superior and inferior vena cava or femoral vein to drain deoxygenated blood into the bypass circuit. Finally, blood enters a venous reservoir, which may be either a rigid, high capacitance reservoir or a closed, soft reservoir before passing through the oxygenator. Mechanics of cardiopulmonary bypass. Let's now follow the blood through the CPB circuit. Venous blood drains into the venous reservoir. The blood is then oxygenated, carbon dioxide is removed, and heated or cooled according to surgical requirements. Finally, oxygenated blood is returned to the systemic circulation through the arterial cannula. Anticoagulation. Since blood contacts artificial surfaces during bypass, anticoagulation is mandatory. Heparin is administered before initiating bypass. The patient is activated clotting time, or ACT, should exceed 400 seconds before cannulation, and CPB is usually started once the ACT exceeds 480 seconds. ACT is measured approximately every 30 minutes, with additional heparin administered when necessary to maintain adequate anticoagulation. At the conclusion of bypass, anticoagulation is reserved using protamine sulfate, which neutralizes circulating heparin. Venous drainage. The amount of venous drainage into the reservoir depends on the several factors, which are central venous pressure, height difference between the patient and the reservoir, diameter of the venous cannula and tubing, and presence or absence of air within the circuit. Adequate venous drains is essential to maintain effective pump flow. Arterial cannulation. The preferred site for arterial cannulation is the distal ascending aorta, just distal to the planned aortic crossclamp. Alternative cannulation sites include aortic arch, innominate artery, subclavian artery, axillary artery, femoral artery, and occasionally the left ventricular apex. Site selection depends on the patient's vascular anatomy and surgical pathology. Pump flow. Pump flow is adjusted to maintain an adequate cardiac index, typically around 2.4 liters per minute per square meter. Maintaining sufficient flow ensures oxygen delivery to all major organs throughout surgery. Continuous monitoring is essential. Patients' parameters include electrocardiogram, blood pressure, central venous pressure, oxygen saturation, trial carbon dioxide, peripheral and core temperature, urine output, and arterial blood gases. The CPB circuit itself is also closely monitored, including blood flow rate, pump speed, gas flow, blood temperature, heat exchanger temperature, arterial line pressure, arterial and venous oxygen saturation, and delivered oxygen concentration. These measurements help ensure safe and effective extracorporeal circulation. Complications of cardiopulmonary bypass. Although highly effective, CPB is associated with several important complications. Systemic inflammatory response. Blood exposure to artificial surfaces activates inflammatory pathways, leading to systemic inflammatory response syndrome, hemolysis, and coagulopathy. Cannulation-related complications. Insertion of arterial cannulas may cause vascular injury, aortic dissection, embolization of atherosclerotic debris, particularly in patients with a porcelain aorta. Heparin-related complications. Patients may develop heparin-associated thrombocytopenia and heparin-induced thrombocytopenia, or HIT. These conditions require prompt recognition and alternative anticoagulation. Systemic embolization. Microemboli may consist of biological material, non-biological particles, and air or gas bubbles. These emboli can cause a stroke, renal hypoperfusion, and splenic ischemia. Modern CPB circuits therefore incorporates filtered cardiotomy reservoir to reduce microembolic load. Cardiac and neurological protection during cardiopulmonary bypass. The next major concept is protecting the myocardium and the brain while the heart is arrested. The primary goal is to reduce myocardial oxygen consumption while maintaining adequate myocardial perfusion. Myocardial protection techniques. Several strategies work together. These include unloading the heart using CPB, arresting the heart with cardioplegia, cooling the myocardium through topical ice or cold saline, systemic hypothermia, and administration of specialized cardioplegia solutions. These measures dramatically reduces myocardial metabolic demand and protect cardiac muscle during prolonged ischemia. Cardioplegia. Cardioplegia may be administered continuously or intermittently. It includes diastolic cardiac arrest by altering the resting membrane potential through high potassium concentrations. Stopping the heart in diastole minimizes oxygen consumption while preserving cellular integrity. Crystalloid cardioplegia. The major formulations are used extracellular cardioplegia. Examples include St. Thomas solutions and Del Nido solutions. This contains high sodium and high potassium, increasing extracellular potassium concentration and preventing myocardial repolarization. Intracellular cardioplegia. These solutions contains lower extracellular sodium, reducing sodium concentration outside the cell and thereby preventing depolarization. Both approaches safely arrest the heart while preserving myocardial function. Blood cardioplegia. Many centers now prefer blood cardioplegia, which combines autologous cold blood with crystalloid solution. Common mixing ratios include 8:1, 4:1, and 2:1. Because blood provides oxygen, nutrients, and buffering capacity, blood cardioplegia often offers superior myocardial protection compared with crystalloid solutions alone. Special considerations: blood conservation in Jehovah's Witness patients. Patients who decline blood transfusion require careful preoperative planning. Preoperative measures include administration of erythropoietin to increase red cell mass, discontinuation of anticoagulant and antiplatelet medications approximately 7 days before surgery whenever possible. Intraoperative strategies include continuous cell salvage, meticulous surgical hemostasis, off-pump coronary artery bypass surgery when feasible, pharmacologic agents such as tranexamic acid or aprotinin to reduce bleeding. Post-operatively, surgeons maintain a lower threshold for re-exploration if bleeding occurs, since minimizing blood loss is critical in patients who cannot receive transfusions. To summarize this page, cardiopulmonary bypass temporarily replaces the functions of the heart and lungs during cardiac surgery. The CPB circuit consists of venous cannulation, reservoir, pump, oxygenator, heat exchanger, and arterial cannulation. Adequate anticoagulation with heparin and ACT monitoring are essential for a safe bypass. Continuous monitoring of patients' physiology and pump parameters ensures adequate organ perfusion. Major complications include systemic inflammation, embolization, vascular injury, and heparin-induced thrombocytopenia. Myocardial protection relies on cardioplegia, hypothermia, ventricular unloading, and optimized perfusion. Blood conservation strategies are especially important for patients such as Jehovah's Witnesses who decline blood transfusions. Understanding these principles is fundamental to safely managing patients undergoing cardiac surgery and optimizing surgical outcomes. Cerebral protection. Now let's begin with cerebral protection. One of the major concerns during cardiac surgery is protecting the brain from ischemic injury. Under normal circumstances, cardiopulmonary bypass provides oxygenated blood to the entire body. However, during operations involving the aortic arch, blood flow to the head vessels may need to be interrupted. In these situations, a specialized cerebral protection technique becomes essential. The two primary strategies for cerebral protections are hypothermia, which is the most important method, and selective cerebral perfusion, performed either in an antegrade or retrograde fashion. Hypothermia lowers the brain's metabolic rate, thereby reducing oxygen consumption and increasing the brain's tolerance to temporary interruptions in blood flow. Deep hypothermic circulatory arrest, or DHCA. Now let's discuss deep hypothermic circulatory arrest, commonly abbreviated as DHCA. DHCA involves cooling the patient's body to very low temperatures so that circulation can be safely stopped during complex cardiac procedures. Cooling dramatically decreases cerebral metabolism and oxygen demand, allowing cardiopulmonary bypass to be discontinued temporarily while surgeons operate in a bloodless field. The duration of safe circulatory arrest depends on the patient's temperature. At approximately 20 degrees Celsius, circulatory arrest is generally safe for 30 to 40 minutes. At around 16 degrees Celsius, arrest can safely extend to approximately 45 to 60 minutes. Modern cardiac surgery often combines DHCA with antegrade cerebral perfusion, or ACP. ACP continues delivering oxygenated blood directly to the brain, allowing surgery to be performed at warmer temperatures while improving neurological protection compared with DHCA alone. Throughout the procedure, electroencephalographic or EEG monitoring is used to assess cerebral electrical activity and confirm adequate brain protection. Several adjunctive medications are also administered. Mannitol helps reduce cerebral edema, and corticosteroids decrease cerebral inflammation and may provide additional neuroprotection. Despite these protective strategies, DHCA is associated with important complications including coagulopathy and platelet dysfunction, systemic inflammatory response, neurological injury caused by cerebral ischemia, particularly in watershed areas. Neurological deficit may be temporary or permanent, depending on the duration and severity of ischemia. Table 20. Commonly used cardiac therapeutics. Let's now review the major cardiovascular drug classes presented in Table 20. The table summarizes each drug class according to examples, mechanism of action, clinical indications, contraindications, and common adverse effects. Angiotensin converting enzyme inhibitors, or ACE inhibitors. Examples include enalapril, perindopril, ramipril, lisinopril. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, resulting in peripheral vasodilation, reduced aldosterone secretion, lower blood pressure, and reduced cardiac workload. Indications. They are commonly used for hypertension, coronary artery disease, congestive heart failure, secondary prevention after myocardial infarction, and diabetes with cardiovascular risks. Contraindications. Avoid ACE inhibitors in patients with bilateral renal artery stenosis, pregnancy, and significant reduction in glomerular filtration rate. Side effects. Common adverse effects include dry cough, hypotension, fatigue, hyperkalemia, renal insufficiency, and angioedema. Angiotensin receptor blockers, or ARB. Examples include candacertan, irbesartan, losartan, olmesartan, telmisartan, and valsartan. ARBs directly block angiotensin II receptors in producing effects similar to ACE inhibitors. They are prescribed for the same indications but are often chosen when patients cannot tolerate ACE inhibitors because of cough. Their contraindications are essentially the same as ACE inhibitors. Their side effect profile is also similar, but with a much lower incidence of dry cough. Angiotensin receptor neprilysin inhibitors, or ARNI. The primary medication is sacubitril and valsartan. Sacubitril inhibits neprilysin, increasing beneficial natriuretic peptides that promotes vasodilation, natriuresis, reduced cardiac workload. Valsartan simultaneously blocks the angiotensin II receptor. Indications: ARNIs are primarily indicated for heart failure with reduced ejection fraction, or HFrEF. Contraindications: avoid in pregnancy and previous angioedema. Side effect: potential adverse effects include hypotension, hyperkalemia, renal dysfunction, and angioedema. Beta blockers. Examples include atenolol, metoprolol, bisoprolol, propranolol, labetalol, carvedilol, and acebutolol. Beta blockers reduce heart rate, blood pressure, myocardial contractility, and myocardial oxygen demand. They also slow conduction through the atrioventricular node. Common indications include hypertension, coronary artery disease, acute myocardial infarction, secondary prevention after MI, heart failure, arterial fibrillation, and supraventricular tachycardia. Contraindications: avoid beta blockers in patients with significant sinus bradycardia, second or third degree AV block, severe hypotension, severe asthma, symptomatic peripheral vascular disease, and decompensated heart failure. Side effects: important adverse effects include bradycardia, hypotension, fatigue, depression, bronchospasm, hyperkalemia, erectile dysfunction, masking of hypoglycemia, and worsening of Raynaud phenomenon or claudication. Calcium channel blockers. This class is divided into two groups. Non-dihydropyridine, examples diltiazem and verapamil. These agents block calcium channels in both cardiac muscle and vascular smooth muscles, reducing heart rate and myocardial contractility while also producing vasodilation. Indications include hypertension, coronary artery disease, supraventricular tachycardia, atrial fibrillation, and diastolic dysfunction. Contraindications: avoid insignificant bradycardia, second or third degree AV block, hypotension, and heart failure with reduced systolic function. Side effects: common adverse effects include hypotension, bradycardia, and peripheral edema. Dihydropyridines. Examples include amlodipine, nifedipine, and felodipine. These drugs primarily relax vascular smooth muscles, causing peripheral vasodilation. Indications: they are used for hypertension and stable coronary artery disease. Contraindications: avoid in severe aortic stenosis and severe liver failure. Side effects: side effects include peripheral edema, flushing, headache, lightheadedness, and hypotension. Sodium glucose cotransporter 2, SGLT2 inhibitors. Examples include canagliflozin, dapagliflozin, empagliflozin, ertogliflozin. Originally developed for diabetes, these medications have become essential therapies for heart failure. Their mechanisms include osmotic diuresis, natriuresis, reproduction in preload, lower afterload, and improved myocardial metabolism. Indications: they are indicated for heart failure with a reduced ejection fraction, diabetes mellitus, and selected patients with chronic kidney disease. Contraindications: avoid in severe chronic kidney disease and patients at high risk for diabetes ketoacidosis. These medications should also be temporarily withheld during acute illness or before major surgery. Side effects. Potential adverse effects include genital yeast infection, urinary tract infections, hypoglycemia when combined with other glucose-lowering medications, diabetic ketoacidosis, and reduced bone mineral density with certain agents. To summarize, successful cardiac surgery requires meticulous cerebral protection, especially during aortic arch procedures. Deep hypothermic circulatory arrest, often combined with antegrade cerebral perfusion, allows surgeons to perform complex repairs while minimizing neurological injury. Equally important is to understand the major cardiovascular medications outlined in Table 20, including ACE inhibitors, ARBs, ARNIs, beta blockers, calcium channel blockers, and SGLT2 inhibitors. Knowing each drug class, its mechanism, indications, contraindications, and adverse effects is fundamental for both the MCCQE examination and everyday clinical practice. Diuretics. We begin with diuretics, which reduces intravascular volume and decreases cardiac workload. They are widely used in hypertension and heart failure. Thiazide diuretics. Examples include hydrochlorothiazide, chlorthalidone, and metolazone. These drugs inhibit sodium reabsorption in distal convoluted tubule, promoting sodium and water excretion. They are considered first-line therapy for uncomplicated hypertension. They should be avoided in patients with sulfa allergy and during pregnancy. Common adverse effects include hypotension, hypokalemia, and polyuria. Loop diuretics. The prototype is furosemide or Lasix. Loop diuretics inhibit the sodium-potassium chloride transporter in the thick ascending limb of the loop of Henle, making them the most potent diuretics. Major indications include congestive heart failure, pulmonary edema, and peripheral edema. Contraindications include severe hypovolemia and significant hypokalemia. Important adverse effects are volume depletion and hypokalemic metabolic alkalosis. Mineralocorticoid receptor antagonists. Examples are spironolactone and eplerenone. These drugs block aldosterone receptors, reducing sodium retention while conserving potassium. They are useful for hypertension, heart failure, and hypokalemia. Avoid them in renal insufficiency, hyperkalemia, and pregnancy. Adverse effects include hyperkalemia, edema, and gynecomastia, especially with spironolactone. Inotropes. The primary drug in this category is digoxin. Digoxin inhibits the sodium-potassium ATP-ACE pump, increasing intracellular sodium and calcium, thereby improving myocardial contractility. It also slows AV nodal conduction. Clinical indications include heart failure and atrial fibrillation for ventricular rate control. Contraindications include second or third degree AV block and hypokalemia. Important toxicities include AV block, bradyarrhythmias, ventricular arrhythmias, visual disturbances such as yellow-green vision, anorexia, nausea, and vomiting. Remember that hypokalemia significantly increases the risk of digoxin toxicity. Anticoagulants. Anticoagulants prevent thrombose formation by interfering with the coagulation cascade. Warfarin. Warfarin inhibits vitamin K recycling, reducing synthesis of clotting factor 2, 7, 9, and 10. Indications include atrial fibrillation, left ventricular dysfunction, mechanical prosthetic valve, and venous thromboembolism. Contraindications include active bleeding, recent surgery, pregnancy, and bleeding disorders. The major adverse effect is bleeding, but clinicians should also remember skin necrosis and paradoxical thrombosis during initiation. Heparins. These include unfractionated heparin and low molecular weight heparins such as dalteparin, enoxaparin, and tenzaparin. They activate antithrombin 3, inhibiting thrombin and factor 10A. Common uses include acute myocardial infarction, acute coronary syndrome, pulmonary embolism, venous thrombosis. Contraindications include active bleeding, thrombocytopenia, recent surgery, and renal insufficiency for LMWH. Important adverse effects are bleeding, osteoporosis with prolonged use, and heparin-induced thrombocytopenia. Direct thrombin inhibitors. The representative drug is dabigatran. It directly inhibits thrombin, preventing fibrin formation. Used for atrial fibrillation, venous thromboembolism, and pulmonary embolism. Contraindications include severe renal impairment, active bleeding, and recent surgery. The major adverse effects are bleeding and gastrointestinal upset. Direct factor 10A inhibitors. Examples include rivaroxaban, apixaban, edoxaban. These drugs selectively inhibit factor 10A, preventing thrombin generation. Indications include atrial fibrillation, venous thrombosis, and pulmonary embolism. Contraindications include active bleeding and severe liver disease, pregnancy, and lactation. Major adverse effects include bleeding and elevated liver enzymes. Antiplatelet agents. These medication inhibits platelet activation and aggregation. Aspirin. Aspirin irreversibly inhibits cyclooxygenase 1, reducing thromboxane A2 production. Indications include coronary artery disease, acute myocardial infarction, and secondary prevention after PCI and CABG. Contraindications include active bleeding and peptic ulcer disease. Adverse effects. Adverse effects include bleeding, gastrointestinal irritation, gastrointestinal ulceration, and reduced renal perfusion. Thienopyridines. Examples include clopidogrel, ticlopidine, and prasugrel. These drugs block the P2Y12 ADP receptors, preventing platelet activation. Common indications are acute myocardial infarction following PCI and following CABG. Major adverse effects include bleeding, thrombotic thrombocytopenic purpura, neutropenia, particularly with the ticlopidine, nucleoside analog. The principal drug is ticagrelor. Like clopidogrel, it inhibits the P2Y12 receptors, but binds at a different site. It is commonly used in acute coronary syndrome and after PCI. Glycoprotein 2B 3A inhibitors. Examples include eptifibatide, tirofiban, abciximab. These agents prevent fibrinogen from binding to the GP2B and 3A receptors, producing very potent inhibition of platelet aggregation. They are primarily used in acute myocardial infarction, especially when PCI is planned. The major risk is bleeding, and they should not be used after recent surgery or in patients with active bleeding. Thrombolytics. Common thrombolytics drugs include alteplase, reteplase, tenecteplase, streptokinase. These agents convert plasminogen into plasmin, which dissolves fibrin clots. Their principal indication is acute ST elevation, myocardial infarction when timely PCI is unavailable. The major complication is bleeding, including life-threatening intracranial hemorrhage. Nitrates. The most common nitrate is nitroglycerin. Nitroglycerin relaxes vascular smooth muscles, causing predominantly venous dilation with some arterial dilation. This decreases preload, myocardial oxygen demand, and relieves angina. Indications include coronary artery disease, acute myocardial infarction, and heart failure, particularly when combined with hydralazine. Contraindications include concomitant use of phosphodiesterase 5 inhibitors such as sildenafil, angle closure glaucoma, and increased intracranial pressure. Common adverse effects include headache, dizziness, weakness, and postural hypotension. To conclude this page, thiazides are first-line therapy for uncomplicated hypertension. Loop diuretics are preferred for pulmonary edema and symptomatic heart failure. Spironolactone improves survival in heart failure but requires monitoring for hyperkalemia. Digoxin increases contractility while slowing AV nodal conduction, but toxicity is more likely with hypokalemia. Warfarin inhibits vitamin K-dependent clotting factors and requires careful monitoring. Heparins provide rapid anticoagulation for acute thrombotic conditions. DOACs such as dabigatran, rivaroxaban, and apixaban are increasingly replacing warfarin for many indications. Aspirin and P2Y12 inhibitors are the foundation of antiplatelet therapy in coronary artery disease. GP2B 3A inhibitors are powerful intravenous antiplatelet agents used mainly during PCI. Thrombolytics rapidly dissolve fibrin clots in selected STEMI patients. Nitroglycerin relieves ischemic chest pain primarily by reducing preload, but should never be combined with phosphodiesterase 5 inhibitors due to the risk of profound hypotension. Exam tips. For every cardiovascular drug, remember the same sequence: mechanism of action, indications, contraindications, and the major adverse effect. This systemic approach makes both clinical practice and exam preparation much easier. Now we begin with lipid-lowering agents, which are fundamental in preventing atherosclerotic cardiovascular disease. Statins. The first and the most important class in the statins are atorvastatin, rosuvastatin, simvastatin, pravastatin, and lovastatin. Statins work by inhibiting HMG-CoA reductase, the rate-limiting enzyme in hepatic cholesterol synthesis. As a result, the liver increases LDL receptors expression and removes more LDL cholesterol from the bloodstream. The major indications include dyslipidemia, primary prevention of coronary artery disease, secondary prevention after myocardial infarction, and reduction of future cardiovascular events. Contraindications include active liver disease and significant muscle disease. Common adverse effects include myalgia, rhabdomyolysis, although rare, and abdominal discomfort. Remember that liver enzymes and muscle symptoms should be monitored during therapy. Cholesterol absorption inhibitors. The next drug is ezetimibe. Unlike statins, ezetimibe works in the intestine by blocking cholesterol absorption through the intestinal brush border. It is primarily used to further lower LDL cholesterol, especially when statins alone are insufficient or not tolerated. Contraindications include significant liver or renal impairment. Potential side effects are similar to statins and include muscle pain, rare rhabdomyolysis, and abdominal discomfort. PCSK9 inhibitors. Next are the PCSK9 inhibitors, including evolocumab, alirocumab. These are monoclonal antibodies that inhibit the PCSK9 protein. Normally, PCSK9 promotes degradation of LDL receptors. By blocking this protein, more LDL receptors remain on the hepatocytes, resulting in profound LDL cholesterol reduction. These medications are indicated primarily in familial hypercholesterolemia and patients requiring additional LDL lowering despite maximal statin therapy. The major contraindication is drug hypersensitivity. Most adverse effects are mild and include injection site reactions, nasopharyngitis, and that's it. Miscellaneous lipid-lowering agents. Other lipid-lowering medications include fibrates, bile acid sequestrants, nicotinic acid. These are used less commonly today but remain useful in selected patients, particularly those with familial lipid disorders. The most common adverse effects involve the gastrointestinal tract. Antiarrhythmics. We now move to antiarrhythmic medications. Before understanding these drugs, we must first understand their cardiac action potential, illustrated in Figure 57. Figure 57, representative cardiac action potential. The ventricular myocyte action potential consists of 5 phases. Phase 4, resting membrane potential. Phase 4 represents the resting state. In pacemaker cell, a slow, spontaneous depolarization occurs due to sodium influx, allowing automaticity. Phase 0, rapid depolarization. Phase 0 is produced by a rapid influx of sodium ions through fast sodium channels. This phase determines conduction velocity through ventricular myocardium. Class 1 antiarrhythmic primarily act here. Phase 1. Initial repolarization. Phase 1 is a brief repolarization caused mainly by transient potassium efflux. Phase 2. Plateau phase. Phase 2 is the characteristic plateau of cardiac muscle. It results from a balance between a slow calcium influx through L-type calcium channels and potassium efflux. This prolonged plateau allows sustained myocardial contraction. Calcium channel blockers mainly affect calcium entry during this phase, especially in nodal tissue. Phase 3. Repolarization. Phase 3 occurs due to potassium efflux. This returns the membrane potential back to its resting level. Class 3 antiarrhythmics prolong this phase by blocking potassium channels. Understanding these phases is essential because every antiarrhythmic drug alters one or more phases of the action potential. Table 21. Antiarrhythmic drugs. Vaughan-Williams classifications. Antiarrhythmics are divided into 4 major classes. Class 1. Sodium channel blockers. These drugs reduce sodium influx during phase 0. Class 1A examples include quinidine, procainamide, disopyramide. Indications include supraventricular tachycardia and ventricular tachycardia. Mechanism. Moderate sodium channel blockade. It slows phase 0 upstroke, prolongs repolarization, and slows conduction. Major adverse effects include torsade de pointes, drug-induced lupus with the procainamide, anticholinergic effects with the disopyramide, and diarrhea. Class 1B examples include lidocaine and mexiletine. Indications include primarily ventricular tachycardia. Mechanism: mild sodium channel blockade and shortened phase 3 repolarization. Adverse effects: confusion, tremor, seizures, and gastrointestinal upset. Class 1C examples include flecainide, propafenone, incanide. Indications include supraventricular tachycardia, ventricular arrhythmias, and atrial fibrillation in selected patients without a structural heart disease. Mechanisms: a strong sodium channel blockade, markedly slow conduction. Adverse effects. Adverse effects include can worsen ventricular arrhythmias, negative inotropic effect, bradycardia, and heart block. These drugs should generally be avoided in patients with a structural heart disease because of their proarrhythmic potential. Class 2 beta blockers. Examples include propranolol and metoprolol. Indications: supraventricular tachycardia and rate control in atrial fibrillation. Mechanism: beta-adrenergic blockade decreases phase 4 spontaneous depolarization and slows AV nodal conduction. Adverse effects include bradycardia, AV block, fatigue, bronchospasm, negative inotropic effects, and erectile dysfunction in some patients. Class 3, potassium channel blockers. Most important drugs are amiodarones and sotalol. Indications include supraventricular tachycardia, ventricular tachycardia, and atrial fibrillation. Mechanism: block potassium channels, prolong phase 3 repolarization, and increase refractory period. Amiodarone has several important toxicities, including pulmonary fibrosis, hepatotoxicity, thyroid dysfunction, photosensitivity, blue-gray skin discoloration, and corneal deposits. Sotalol also has beta-blocking properties and may cause bradycardia, heart block, and torsade de ponta. Class 4, calcium channel blockers. Examples include verapamil, diltiazem. Indications: supraventricular tachycardia and rate control in atrial fibrillation. Mechanism: block L-type calcium channels, slow phase 4 depolarization in the AV node, and a slow AV nodal conduction. Adverse effects include bradycardia, AV block, and hypotension. Important clinical pearl. Finally, remember the note at the bottom of the table. All arrhythmic drugs have the potential to be pro-arrhythmic, meaning they can paradoxically induce dangerous arrhythmias. In addition, amiodarone is unique because it exhibits class 1, 2, 3, and 4 properties, making it one of the most effective but also one of the most toxic antiarrhythmic medication. To summarize this page, statins are first-line therapy for LDL reduction and cardiovascular risk prevention. Ezetimibe decreases intestinal cholesterol absorption. PCSK9 inhibitors provide powerful LDL reduction in high-risk patients. The ventricular action potential consists of 5 phases, and antiarrhythmic drugs work by modifying these phases. Class 1 drugs block sodium channels. Class 2 drugs are beta blockers that slow AV nodal conduction. Class 3 drugs block potassium channels and prolong repolarization. Class 4 drugs are calcium channel blockers that primarily affect the AV node. Always remember that antiarrhythmics can themselves cause arrhythmias, so careful patient selection and monitoring are essential. Table 22, actions of alpha and beta adrenergic receptors. The sympathetic nervous system works primarily through alpha and beta receptors. There are 4 clinically important receptor subtypes: alpha 1, alpha 2, beta 1, and beta 2. Each receptor is distributed in different organs and produces distinct physiologic effect. Alpha 1 receptors. The easiest way to remember alpha 1 receptors is that they generally cause a smooth muscle contraction. Cardiovascular system. Activation of alpha 1 receptors cause vasoconstriction of vascular smooth muscles. This constricts skin vessels, skeletal muscle vessels, and splanchnic circulation. The result is increased systemic vascular resistance and increased blood pressure. Alpha 1 stimulation can also increase myocardial contractility indirectly and may produce a reflex decrease in heart rate because of the rise in blood pressure. Respiratory system. There is a little direct respiratory effect from alpha-1 receptors. Skin or dermal effects. Alpha-1 receptors stimulate pilomotor muscle contraction, producing goosebumps, and apocrine sweat glands contraction. Eye. In the eye, alpha-1 stimulation contracts the radial muscles of the iris. This causes mydriasis or pupil dilation. Importantly, accommodation is not affected. Gastrointestinal tract. Alpha-1 activation inhibits the myenteric plexus. This decreases gastrointestinal motility. It also contracts the anal sphincter, reducing bowel emptying. Genitourinary system. Alpha-1 receptors produce contraction of pregnant uterus, urinary bladder neck, and internal urethral sphincter. In males, they also facilitate penile and seminal vesicle contraction and ejaculation. Metabolic effects. Alpha-1 receptors stimulate the liver to perform glycogenolysis and gluconeogenesis. These processes increase blood glucose during stress. Alpha-2 receptors. Unlike alpha-1 receptors, alpha-2 receptors are primarily involved in negative feedback regulation. Cardiovascular effect. Peripherally, alpha-2 receptors help regulate vascular tone. They can produce vasoconstriction but also oppose excessive alpha-1 mediated vasoconstriction under certain conditions. More importantly, centrally, they reduce sympathetic outflow, leading to lower heart rate, reduced blood pressure. Genitourinary effects. Alpha-2 stimulation relaxes smooth muscle walls. Metabolic effects. Like alpha-1 receptors, alpha-2 receptors also promote fat cell lipolysis. Beta-1 receptors. Beta-1 receptors are concentrated primarily in the heart and kidneys. A simple mnemonic is beta-1 equals to 1 heart. Cardiovascular effect. Activation of beta-1 receptors produces 3 major cardiac effects. First, increased myocardial contractility, which improves cardiac output. Second, accelerated SA0 conduction, increasing heart rate. Third, enhanced AV0 conduction and increased automaticity, which may accelerate ectopic pacemakers. Overall, beta-1 stimulation results in positive chronotropy, positive inotropy, and positive dromotropy. Kidney. Beta-1 receptors stimulate the juxtax glomerular cells. This increases renin release. Renin activates the renin-angiotensin-aldosterone system, helping maintain blood pressure. Metabolic effects. Beta-1 stimulation promotes lipolysis, glycogenolysis, providing energy during stress. Beta-2 receptors. Beta-2 receptors generally produce a smooth muscle relaxation. An easy mnemonic is beta-2 equals 2 lungs. Cardiovascular system. Beta-2 stimulation decreases vascular smooth muscle tone. This causes vasodilation, reduced peripheral resistance, and that's it. Respiratory system. One of the most clinically important beta-2 effect is bronchodilation. This is why Beta-2 agonists are first-line medications for asthma and COPD. I. Beta-2 receptor relaxes the ciliary muscles. Genitourinary system. Beta-2 stimulation relaxes bladder wall and uterus. This explains why beta-2 agonists such as terbutaline have been used to delay premature labor. Metabolic effects. Beta-2 receptors stimulate gluconeogenesis and fat cell lipolysis. They also contribute to glycogen breakdown in skeletal muscle. Clinical summary of receptor functions. Let's briefly summarize these receptors. Alpha-1, vasoconstriction, mydriasis, urinary retention, and increased blood pressure. Alpha-2, reduced sympathetic output, lower blood pressure, central inhibition of norepinephrine release. Beta-1, increased heart rate, increased contractility, and increased renin secretion. Beta-2, bronchodilation, vasodilation, uterine relaxation, and bladder relaxation. Table 23 commonly used drugs that act on alpha and beta adrenergic receptors. Now let's review the important drugs that target these receptors. Alpha-1 agonists. Examples include phenylephrine and methoxamine. These drugs cause vasoconstriction. Clinical uses include hypotension, nasal decongestion, and pharmacologic pupil dilation. Alpha-1 antagonists. Examples include prazosin, phenoxybenzamine. These drugs produce vasodilation, and clinical indications include hypertension, benign prostatic hyperplasia, pheochromocytoma, particularly with phenoxybenzamine. Mixed alpha-1 and alpha-2 agonists. Examples include epinephrine and norepinephrine. These powerful catecholamines are widely used during shock and cardiac arrest because they stimulate multiple adrenergic receptors. Mixed alpha antagonists. The classic drug is phentolamine. It blocks both alpha-1 and alpha-2 receptors. Common uses include pheochromocytoma, catecholamine-induced hypertensive crisis, and treatment of vasopressor extravasation. Alpha-2 agonists. Important examples are clonidine and methyl-dopa. Both reduce sympathetic outflow from the brain. Clinical use: hypertension, resistant hypertension. Methyl-dopa remains a preferred antihypertensive in pregnancy. Alpha-2 antagonists. Example includes euhembine and mirtazapine. Euhembine increases sympathetic activity. Mirtazapine is primarily used as an antidepressant. Beta-1 agonists. Important drugs include norepinephrine and dobutamine. Dobutamine is especially used in acute heart failure, cardiogenic shock, and stress echocardiography. It improves cardiac contractility with relatively little increase in heart rate. Beta-1 antagonists. Common selective beta-1 blockers include metoprolol, acebutolol, alpranolol, atenolol, esmolol. These drugs reduce heart rate, contractility, and myocardial oxygen demand. Clinical uses include hypertension, coronary artery disease, heart failure, and rate control in arrhythmias. Esmolol is particularly valuable because of its very short half-life, allowing rapid titration in intensive care and preoperative settings. Non-selective beta agonists, example include isoproterenol, epinephrine. These stimulate both beta 1 and beta 2 receptors. Clinical effects include increased heart rate, increased contractility, and bronchodilation. Epinephrine is the drug of choice for anaphylaxis, cardiac arrest, and severe asthma exacerbation. Non-selective beta blockers. Examples include propranolol, temolol, nadolol, pendolol, carvedilol. Clinical uses: hypertension, arrhythmias, migraine prophylaxis, essential tremors, portal hypertension, and glaucoma in the case of temolol. Carvedilol is unique because it blocks both beta receptors and alpha-1 receptors, making it particularly useful in chronic heart failure. Beta-2 agonists. Examples include albuterol and terbutaline. These drugs relax bronchial smooth muscles and are first-line bronchodilators for asthma. Terbutaline also relaxes uterine smooth muscles and may be used as a tocolytic in selected situations. Beta-2 antagonists. The classic example is butuxamine. Although primarily of pharmacologic interest, it illustrates selective beta-2 blockade. High-yield examination pearls. For examination, remember these key associations. Alpha-1 is vasoconstriction, mydriasis, urinary sphincter contraction. Alpha-2 decreases sympathetic outflow. Clonidine and methyl-dopa are alpha-2 agonists. Beta-2, one heart, raises heart rate, contractility, and renin release. Beta-2, two lungs, causes bronchodilation, vasodilation, uterine relaxation, and bladder relaxation. Phenylephrine is a selective alpha-1 agonist used for hypotension. Prazosin blocks alpha-1 receptors and treats hypertension and benign prostatic hyperplasia. Dobutamine is the preferred beta-1 agonist for cardiogenic shock. Metoprolol and atenolol are cardioselective beta-1 blockers. Albuterol is the prototypical B2 agonist for asthma. Epinephrine stimulates alpha and beta receptors and is the first-line treatment for anaphylaxis and cardiac arrest. Understanding the physiologic actions of each receptor subtypes makes it much easier to predict both the therapeutic effects and adverse effects of the adrenergic drugs. An essential concept for cardiology, anesthesia, emergency medicine, and the MCC QE examinations. Thank you very much for attending this lecture and all the series in this lecture. And this was the last lecture from the cardiology and cardiac surgery. So see you in the next lectures and the next topic lectures. If you're new to the channel, don't forget to like and subscribe. See you in the next videos.